It is really a very nice feeling to see that the Society of Internal Medicine is now fully established. The opening ceremony yesterday was testimony to the amount of work that has been done, and it is really truly amazing. So congratulations to the leadership of the society, and in particular to the president, who is, I haven't seen so much energy in anybody. तो आपकी मेटाबॉलिज्म को देखना पड़ेगा कुछ किसी तरह से कि क्या कुछ स्टडी करनी पड़ेगी इसके बारे में. You don't have NAFLD. Okay, so my talk is based, the task I was given was to look at NASH, the new Millennium Pandemia. इसके साथ मैंने add कर दिया requiring a truly multidisciplinary approach. So I think it is a very relevant topic and a very relevant talk for this audience, because बहुत सारे लोग इसमें contribute करेंगे इस session में. I have no disclosures. अच्छा, let me start with a little bit of a controversy. और वो controversy ये है कि there is a name change that is going on. You must have heard that there is a move towards changing the name of NAFLD to MAFLD, which is metabolically associated fatty liver disease. Now, why is this happening? Because NAFLD is suggested to be a disease of exclusion instead of being defined by inclusion. NAFLD is a vastly heterogeneous entity and cannot be managed as one single condition. On top of that, NAFLD patients do consume alcohol. They may consume less alcohol, and the impact of alcohol may be not that significant, but it is certainly there. And the word non trivializes the problem, while the word alcoholic demeans the patient, and there may be a stigma attached to this name change, to the name of NAFLD. So those are some of the reasons why this is a entity that requires a change in name. On the other hand, MAFLD emphasizes the underlying condition of systemic metabolic dysfunction, and the next speaker, the next talk, will concentrate much more on this, so I don't need to do that. And therefore, it provides a greater homogeneity in trying to understand and label this disease. On top of this, MAFLD allows alcohol consumption, but then calls it MAFLD plus alcoholic liver disease. So that confusion is also removed of how much alcohol is being utilized by the patient and what is the influence of that alcohol on MAFLD. So we are moving towards a name change, but it will bring a lot of problems with it. The problems being that all of the information, the literature, the knowledge that we have at the moment deals with NAFLD or is labeled as NAFLD or NASH and not MAFLD. So this will be a change that may be a little bit painful. Now, as I said, the basis of most of NAFLD and NASH is the metabolic syndrome, and I don't need to go into this in detail. Everybody knows that this is abdominal obesity, glucose intolerance, insulin resistance, hypertension, atherogenic dyslipidemia, which means a raised triglycerides, low HDL levels, and a pro-inflammatory, pro-thrombotic state, which leads to NAFLD and NASH on the one hand, and also causes cardiovascular disease and contributes to diabetes. There are other risk factors as well, and the emerging associations are hypothyroidism, sleep apnea, hypopituitarism, and in particular, polycystic ovarian syndrome. So these have to be recognized as risk factors for MAFLD as well. Whatever we want to call it, NAFLD or MAFLD, it is a global disease of some prominence. As you can see on this world map, there is no area, or except for Africa, there is no area which is below 20%. And we are in the Asia-Pacific region. Nearly 27% of our patients, of our population, would have some sort of NAFLD. Maybe it's just steatosis and not NASH, but they will have extra fat in their liver. Of course, in South America, this is probably the highest in number, as in the US as well. So a truly global disease, which is really not sparing any populations. What is the situation here? Some of these studies from our institution and from other institutions suggest that nearly 20 to 30% of our general population has some form of fatty liver disease. Maybe just simple steatosis as shown on an ultrasound, but about 20 to 30, about a third of the population has NAFLD. Individuals at risk of diabetes with an Indian diabetic risk score of more than 60, 60% of these people will demonstrate NAFLD. Nearly a quarter of our population suffers from type 2 diabetes, about 25%, one of the highest cohorts that we have in the country. And individuals with type 2 diabetes mellitus in our diabetic clinics, 70 to 80% of them have NAFLD if they are looked at properly. What is NAFLD doing in terms of the disease burden itself? So this is a very nice study which spans over 3 decades and looks at various risk factors for chronic liver disease of what they're doing. And as you can see, from 1998 onwards, hepatitis C, which has been our main liver disease, is going down because of good diagnosis, screening, and very easy and cheap treatment. And this will continue to go down, inshallah, and we will be able to eliminate this. Hepatitis B is staying stable, and this is not causing a huge amount of problems. Alcoholic liver disease is with us for sure, and it is staying stable or maybe going up a little bit, but see what's going up the most, and that is NAFLD-related chronic liver disease. And this is now our number one, or will become our number one problem as hepatitis C recedes. This is the topmost diagnosis for liver transplantation in many countries in the world, particularly the Western countries, but rapidly we are catching up. What is also becoming important is the quality of life issues in NAFLD. And this is some work that we did on patient-reported outcomes, PROs, which are becoming important with every disease. And what are patient-reported outcomes? They are any reports of patients' perspectives about the impact of disease and treatment on their health status, without the interpretation of a clinician or anyone else. So these are symptoms or signs that patients report themselves. And data clearly show a significant PRO burden of NAFLD. There are increased rates of cardiovascular morbidity, sleep apnea, depression, and anxiety. And the most important thing, overt fatigue seems to be very common among NAFLD patients. So the quality of life is affected in more ways than one. Patients with fatigue have significantly more impairment of health-related quality of life and work productivity. So this is a disease which is affecting not just people's lives, but also the work of the society and the country. So turning to pathogenesis, and I'm sorry, because of lack of time, we're just going to skim over a few of these things which I think are important. So what is the most critical point in the pathogenesis of NAFLD? Does anybody want to answer that question very quickly? And that is the transition from NAFLD to NASH. And NASH means steatohepatitis, of course, and NAFLD could just mean steatosis. And this is the multi-hit hypothesis that we have been familiar with for quite some time. So 3 hits, one after the other. This is normal liver. There is insulin resistance, which is the basis of the metabolic syndrome, which is the first hit. This creates simply steatosis, no inflammation. And then the other parts of the metabolic syndrome come in, which is a second hit that cause NASH and inflammation. And this leads to, NASH will always lead to fibrosis, if not treated, if not checked. And this is related to the cytokine disturbances, to adipokines, we've just heard, adenopathinectin, oxidative stress, and apoptotic pathways and so on are affected. So this is the progression of NASH that leads to eventually to fibrosis. What is becoming more important and more topical in many other diseases as well is the role of gut microbiota. And NAFLD is associated with gut dysbiosis. There is no doubt about that, and I'll show you some data on this. NAFLD has been found to be associated with reduced abundance of several bacterial taxa. And this is really a ripe area for research for any young minds that are here to take up this in our populations. We don't know this. NAFLD patients have higher concentrations of select fecal and serum metabolites, indicating a specific intestinal microbiome community. And I will draw your attention to this paper in Gut in 2019. I don't have time to go through this in detail, but beautiful illustrations and beautifully illustrated paper of how the gut microbiomes are influencing the development of NAFLD and in particular of NASH. So do read it if you have time. This is Gut 2019. What does the microbiome do? It modulates insulin resistance and metabolism. So the gut, for some reason, if it becomes leaky, it allows the mycobacteria to go through. There is metabolic endotoxemia, and this leads to lipogenesis, inflammation, oxidative stress, and various changes in the liver, and more importantly, inflammation in the fat, as was mentioned a while ago, and oxidative stress, and so on. And there is some inflammation in the muscle and insulin resistance. But the main problem is the visceral fat, which is, I think, what we, because of this is the reason why we have so much of NAFLD and NASH in our population, because we mainly have visceral obesity, which means a big belly, but not so much fat on the rest of the body. And the visceral fat is an organ that is alive, and it is an organ that responds to inflammation. It responds to inflammation by the release of various cytokines, which then again disturb the lipid milieu and causes lipid deposition in the liver and other places. So it is not so much as the fat in the muscle, not so much a skeletal fat, but the visceral fat, which is very important. And this plays out in the understanding of what we call lean NASH. We have about 20% of our patients maybe with normal BMIs, and you call them lean because they are within the normal BMI range, and yet they have fatty liver disease. And that is because of the fact that the visceral fat is playing the part, and not the fat which is shown below, which is the fat which happens particularly in the Western populations. Although they may be consuming the same type of diet, the results are different. Lean patients had better metabolic and liver histology profiles. Lean patients have appropriate metabolic adaptation to an obesogenic environment, thus resistant to obesity. The compensatory mechanisms include increased bile acids and FXR and distinct gut microbiota profiles. So let me come to the clinical spectrum of NAFLD and NASH, and this is something that is important to understand. 2/3 of the patients, as shown on this slide, will just have fatty liver, will not have NASH. 1/3 will have NASH. Out of this 1/3, there'll be a group that will develop cirrhosis. There will be a group that will decompensate, and there will be a group that will develop HCC. But look where the HCC is situated. It is not just situated in NASH, it is also situated in the area of fatty liver disease alone, of just steatosis, for example. So not directly sometimes related to NASH, which is a little bit of a worry. So this is what we are talking about. On the right-hand side, there is just steatosis with a little bit of lobular inflammation, but then there is the NASH, which is hepatocyte ballooning, lots of fibrosis, and eventually leading to cirrhosis. And this is what we want to avoid. Now, is there a difference between having just some fat in the liver and having NASH, which is steatohepatitis? And definitely there is a difference. This is a study that looks at the 6 separate studies that look at a long-term follow-up of about 15, 14 years. So the red is cardiovascular mortality, the green is the blue is liver-related mortality, and green is other mortality. Even if you look at the no NAFLD patients, there is cardiovascular mortality and there is other mortality. There is very little liver mortality. When you start to accumulate fat in the liver, look what happens to your cardiovascular mortality. It goes up significantly as compared to no fat. And liver mortality, of course, goes up a little bit. But the real dramatic point is NASH. Cardiovascular mortality goes up or remains the same. Liver-related mortality goes up, and so does other mortality, which goes up as well. So the transition from NAFLD to NASH is an important one in more than one ways, in not just in liver disease, but also in cardiovascular mortality and in other mortalities. This is a very interesting and very nice study, and I will just spend a little bit of time on this. And this is prevalence per 10,000 patients of HCC among subgroup of patients with NAFLD, right? Now, here are the subgroups. Non-cirrhotics, there is about 4.6 prevalence per 10,000 patients. We've already said that non-cirrhotics can develop liver cirrhosis. Non-cirrhotics with certain risk factors, males, senior smoker, diabetes, high ALT, it goes up to, dramatically goes up to 45.5 prevalence per 10,000. Non-cirrhotics, male, senior, smoker, diabetes mellitus, high ALT, which means NASH, insulin user, goes up to 69.4. And of course, if you become a cirrhotic, this goes to 375 per 10,000. So a dramatic increase in cirrhotics and a significant increase in the non-cirrhotics with risk factors. And these are the people that you need to really take seriously when they do not have cirrhosis. They will still develop liver cancer. So this is a meta-analysis of studies looking at NASH and HCC in patients without cirrhosis. And you can clearly see that there is a shift towards the development of HCC in patients with NASH. Patients with NASH have a 261% increased risk of HCC when compared to all other etiologies of liver disease. Remember, all other etiologies of liver disease may not have that much high prevalence, and therefore 261 is a big number. But clearly the message is that even in non-cirrhotics without liver cirrhosis, HCC can happen in patients with NASH. And remember, it is not just liver cancer that NAFLD will propagate. It is breast cancer, it is colorectal cancer. 25,000 subjects with median 7.5 years of follow-up, overall cancer incidence per 100,000, 782 NAFLD, 582 no NAFLD. So other cancers are also aggravated. We know about cardiovascular disease accounts for at least 40% of total deaths in NAFLD, and thus is a predominant cause of death more than anything else. And what is happening again is the inflammation going through the liver and setting up a pro-inflammatory situation and a pro-thrombotic situation. Data most strongly support an increased cardiovascular risk in those with NASH and fibrosis. So again, the importance of NASH is very evident. Coming to diagnostic modalities, we have some non-invasive tests, and we finally have a liver biopsy. Liver biopsy is the gold standard, but of course, many patients or almost no patient will agree to this, very few will agree to this. Non-invasive tests are there, and normally what happens is an ultrasound which has been done for various reasons, abdominal pain, this, that, and the other, and they have found fat in the liver. And here is a patient sitting in front of you in the clinic with that report of an ultrasound which shows fat in the liver. Doctor Sahab, is charbi ka kya karna hai? Kya hoga? And then, of course, what we do is a fibroscan. We look at the liver enzymes, and there are various scores that have been described. So the commonest thing that we do as hepatologists is to send this patient to a fibroscan. Now, is a fibroscan good modality to measure fat, to quantify fat, or is it not? And it quantifies fat in the sense that it gives you an S0, so that there are very few cells, hepatocytes that are affected, to S3, which is the maximum number that is affected. But suffice it to say that FibroScan lacks sufficient positive predictive value to be used alone to predict NASH and fibrosis. And therefore, we have these other scores which are basically calculations that we've heard this morning about, and they are okay at the extreme ends. They will look at, they are good at telling you that there's no advanced fibrosis. They are good at telling you that there's advanced fibrosis, but the intermediate stage is not very well picked up with these, and therefore they both lack positive predictive value when used alone. These are easily found on handheld calculators. The people can be quite easily trained to calculate a FIB4 and NAFLD. Therapies, I'm not going to go into detail. The main question is NASH reversible? Is liver fibrosis reversible? There are no approved therapies as yet, so no point in talking about. The best way to counter the effects of NAFLD is weight loss. And these are multiple studies that are available, and these are the figures that are agreed upon. More than 10% of weight loss will result in fibrosis regression. More than 7%, there may be NASH resolution in a good number of patients. But the difficulty is, how can you get people to sustain this weight loss beyond 1 year? That is the challenge. Less than 18% of people, or less than 10% of people, will sustain this weight loss of more than 10% over a period of time. Exercise is important to maintain a lifestyle change. What patients should understand, this exercise alone, even if it is intensive, will not reduce weight to that extent as the diet component will reduce it. Just a quick word about semaglutide, which has only last week been approved by the UK authorities as a weight reduction drug, and it works well. These are multiple studies, significant amount of weight loss as compared to other GLP-1 agonists versus liraglutide and so on. So this drug does work, and this is comparing semaglutide versus canagliflozin, and again there is a significantly different weight loss to semaglutide. So this is something that is now going to be used as an armamentarium. One question to cover that is always asked is, do we give these people statins who have raised ALT levels in any case? And the answer is a strong yes, because the aggressive modification of CVD risk factors should be considered in all of these patients, and they should be given statins even though the ALT may be 70, 80, 100. This is not going to make any difference or be detrimental. The role of bariatric surgery is very much there as a weight loss mechanism, and this is a biopsy looking at pre-surgery and post-surgery, and you can see all the fibrosis is gone, the steatosis is much better. This is 8.5 months after surgery. So it can be considered, but it has to be done in a very conscientious manner. It is not for everybody. It is not for everybody to do bariatric surgery as well. This should be a trained team of people who does this and gives every chance to the patient to try and lose weight beforehand by natural means. Final part of my talk is to emphasize on the multidisciplinary care of these patients, which is the key to success. And this is, I think, where different societies need to get together and focus on these patients in a very concentrated manner. That is the only reason why I'm here and in trying to promote this multidisciplinary care to the internists that are sitting here. So if you look at a pyramid of these patients, the majority of people will be seen in primary care and internal medicine. Then they will go to a diabetology clinic if they're found to be diabetics, where they may meet a dietitian and dietetics. Some of these patients may be referred to hepatology, and some of these patients may be referred to cardiology. They may eventually end up in oncology and surgery because of their complications, which is already too late. So the big base is here, is primary care, internal medicine, diabetes, and hepatology comes really quite far away. Having said that, we did a survey on the knowledge of physicians and their practices, and we got what we really was, what we expected. The hepatologists saw the greatest number of NAFLD patients annually as compared to family physicians, primary care providers, and this should be the opposite. This should not be this number. The primary sources of knowledge acquisition for hepatologists were international conferences. The internet was the second most common source of knowledge for PCPs. So really not a very well-trained situation here. Despite the growing burden of NAFLD, a significant knowledge gap remains for identification, diagnosis, and management of NAFLD. So should NAFLD be a part of standard screening for everyone with type 2 diabetes? Now, diabetologists are very, very good at screening all of these things. If you look at anybody with a diabetes chart, you will find all of this, head to toe. You may not ever find, this is our common observation, you may not even find an ALT that has been done. So this needs to change, and this is something that needs to be inculcated into people's practices. And also, they should be aware of the strong predictors of NASH and fibrosis, which I've again alluded to as age 50, type 2 diabetes, first degree relative with NAFLD and cirrhosis, etc. So, so this is a call to action. We can teach these patients on how to, the primary care providers on how to do this. So devolution of care is important. If an ALT is normal, there is periodic evaluation and standard care. If there are risk factors, then you go on to assessment of fibrosis, which may be as easy as looking at a fibroscan or using fibrosis markers and so on. If there is, or if the ALT is abnormal, you go to an assessment of fibrosis. No advanced fibrosis, periodic evaluation. If there is indeterminate fibrosis, you may need a liver biopsy to define NASH. If there is advanced fibrosis, this is the time that you want to refer to a hepatologist and take care of this. Now, societies are moving towards multidisciplinary guidelines. This is an example of American Association of Clinical Endocrinology practice guideline for the diagnosis and management of NAFLD in association or co-sponsored by the American Association of Study of Liver Disease. EASL has also collaborated with the EASD, European Association for Study of Diabetes, and European Association for Study of Obesity. So this is the future, and this is where we need to go with our multi-society, multidisciplinary guidelines. So last slide, when we look at a consensus, raising the profile of NAFLD as a public health issue will require clear messages about the condition, its consequences, and what action is required. Primary care providers and diabetes specialists can play a critical part in identifying and referring patients with advanced fibrosis to liver specialists and dealing with most of the patients themselves. They have to be empowered to do this. The majority of people living with NAFLD can be managed in primary care or in internal medicine. NASH and fibrosis is an important predictor of long-term liver-related outcomes and overall mortality in people living with NAFLD. NAFLD is not mentioned in the current guidelines from the WHO on the detection, diagnosis, and treatment of major non-communicable diseases. It needs to get into the NCD agenda, and it needs to get it through the diabetologists and through other people. Access to treatment programs for NAFLD require that they be incorporated into relevant national healthcare policies and guidelines and be adequately funded. A national strategy for NAFLD is lacking in almost every country in the world as we speak. Thank you for your attention.
Thank you so much for such an elaborative talk, Professor Saeed Hamid. We are honored to have the next speaker who has graced us and has honored us in this conference, has come all the way from Netherlands, Professor Dr. Thomas Unger. who is a professional with very high standing